So people should start screening at the age of 50 if they're healthy, average risk individuals. That means that there's no family history and they're going to the doctor to stay well. For patients who have a family history of colon cancer, usually the recommendation is starting 10 years before the youngest person in the family had colon cancer or at age 40. So family history increases the risk and screening should start younger. There is also some recommendations for African Americans to start at a younger age, 45, because there's actually a higher incidence of mortality of African Americans with colorectal cancer. So screening is really important in terms of finding out if someone is average risk and healthy or if someone has an increased risk. There are also other cancers that may actually put a patient at increased risk for colon cancer, such as endometrial or uterine and ovarian. Those patients sometimes may have a Lynch syndrome, which is a mutation in the mismatch repair genes that would have to be looked at for colorectal cancer starting at a very young age, sometimes in the 20s. So family history is crucially important in helping distinguish when a person should start screening. The African American screening at a younger age is only a recommendation by one of the GI societies called the American College of Gastroenterology. Otherwise, the national guidelines do not recommend African Americans start at a younger age. And there are multiple sets of guidelines. The U.S. Preventative Services Task Force, which is a governmental agency, actually, in addition to recommending screening to start at age 50, recommends that screening stops at age 75 and definitely after age 85. Now, of course, age is relative based on function, so I think everybody deserves to have that discussed with their doctor and be evaluated, not just as a number alone. But at some point, you have to assess the upper limit of screening to prevent a cancer based on functional status and life expectancy. I think what we have to understand with any procedure, there are risks associated with it. I tell my patients, even crossing the street, there's a risk to getting to the other side. So with colonoscopy, there are risks associated with it. There's a very low risk of perforation or bleeding after remove a polyp. The risk of perforation is 1 in thousands. The risk of developing colon cancer obviously outweighs those risks, but patients have to recognize that there are risks to procedures. Truthfully, the biggest risk that I tell patients is that even with a colonoscopy, there's never a 100% guarantee that we could prevent cancer. We decrease the risk substantially with colonoscopy, but nothing in life, unfortunately, is 100%. Truthfully, there's very little risk of infection for scopes that are processed appropriately. In all the cases in which there have been infection reported for conventional endoscopy or colonoscopy, it's been human error. As long as scopes are processed in a particular way, in a meticulous way, and that's something that people, particularly patients, can ask their doctor about, there should be no risk of infection. There was just a recent report that we're trying to get details on about an infection for a particular scope that would not be used for conventional colonoscopy. So we're doing amazing preventing colorectal cancer. This is one of the great success stories of public health, particularly in my career. Over the past 10 years, we've dropped the incidence of colorectal cancer by 30%. That's almost unprecedented. And actually, not only is the incidence dropping, but the death rate from colon cancer is dropping. So we're doing a better job at preventing it, and we're doing a better job at treating it. So it's really exciting. In fact, colorectal cancer for men and women is still the second leading cause of cancer-related death. If this continues and we get more people screened and we keep preventing the disease, it will start dropping down that list. I don't think we'll ever wipe out colon cancer completely, but I expect it to drop off that list of top 10 killers, that's for sure. And in fact, that's part of my mission. We've been screening more and more patients, and in New York City, we've gotten up to 70% screening rate, but there's a national benchmark that we're trying to get to. The campaign is called 80 by 18, 80% screened by 2018. This is something coming from the National Colorectal Cancer Roundtable, which I'm a part of and really thrilled to be part of. And we're trying to get some people to cross the finish line at 80% screen. The more people we can get screened, the more disease we can prevent. So it really comes down to that concept of prevention. And unfortunately, the concept of prevention is not in the American psyche of healthcare. We go to a doctor when we're sick. What we're trying to do is tell patients to go to a doctor when they're well, and we can keep you well. Don't wait till you get sick.